Hey everyone! So in the ICU, our sickest patients can't always just tell us what's wrong. But what if we could get a direct look inside their cardiovascular system to see exactly what's happening, beat by beat? Well, that's the whole idea behind invasive hemodynamic monitoring, and today we're going to decode it together.
But before we dive into any of the fancy tech, let's get one thing straight. This is the single most important rule. These tools, they give us data, not answers. The numbers are just clues, and they are absolutely no substitute for looking at your patient and using your clinical judgment. This idea is the foundation for everything we're about to cover.
All right, so here's our game plan. We're going to build this up layer by layer. We'll start with a real fundamental concept, central venous pressure. Then we'll get a live beat-by-beat view with the arterial line and see what advanced data we can pull from it. And finally, we'll put it all together with the most comprehensive tool we've got, the pulmonary artery catheter.
Okay, first up is CVP. This is one of the most common measurements you'll see, and it's really all about a simple question. How full is the tank? It's our first clue about the body's fluid volume.
So, what is it really? CVP is just the pressure inside the right atrium. You can think of it as the filling pressure for the right side of the heart. It tells us how much blood is returning to the heart right before it gets pumped out to the lungs. In medical terms, we call this preload.
Now, here's where it gets interesting. Turning that number into a clinical picture. A normal CVP is somewhere between 2 and 10. If you see a high CVP, you gotta start thinking, is the patient fluid overloaded? Or maybe the right side of the heart is struggling to pump, causing a backup. On the flip side, if it's low, they're probably dry, dehydrated, maybe they lost volume from bleeding, or their veins are just too relaxed. This one number helps us start answering that huge ICU question. Does this patient need more fluid or less?
All right, let's move on. You know how a regular blood pressure cuff gives you a snapshot in time? Well, the arterial line gives you the whole movie. You get a continuous, real-time look at the blood pressure, second by second.
An A-line is just a tiny, thin catheter that we place directly inside an artery, usually the radial artery in the wrist or sometimes the femoral artery down in the groin. This gives us a direct, unfiltered measurement of pressure inside the arterial system with every single heartbeat.
But here's the catch. Just having an A-line isn't enough. The waveform it produces has to be accurate. If the system is what we call underdamped, the waveform gets all spiky and whipped, giving you a systolic number that's way too high. If it's overdamped, it gets flattened out, and you get a reading that's falsely low. Getting this waveform just right is absolutely critical.
And that right there is why we use it. When that waveform is dialed in perfectly, the A-line is the gold standard. It's way more accurate than an automatic cuff, which is essential when you're adjusting powerful blood pressure medications, where every single point matters.
Okay, so we've got this great real-time pressure, but what if I told you we could squeeze even more information out of that simple A-line? Well, that's where advanced systems come in. They use some pretty smart software to analyze that same waveform and unlock a much deeper story about the heart's performance. Just by looking at the shape of that pressure wave, these systems can figure out the patient's stroke volume. That's how much blood the heart pumps with each beat. From there, it calculates cardiac output, the total amount of blood pumped per minute. But the real game changer here is a value called stroke volume variation.
Stroke volume variation, or SVV, is another really cool way to look at that preload we talked about. It measures how much the patient's stroke volume changes as they get a breath from the ventilator. This is an incredibly powerful tool for answering that same crucial question. If I give this patient more fluid, will it actually help their heart pump better?
All right, if there's one number you're going to remember from this section, it's this one, 13%. In a patient who is well hydrated, a normal SVV is less than 13%.
And here's the super easy way to remember what it means. High and dry. If that SVV number is high, so above 13%, the patient is likely dry and would probably benefit from more volume. It's a really slick way to predict fluid responsiveness. But, and this is a big but, SVV isn't perfect. It's only accurate under very specific circumstances. If the patient is taking their own breaths, if their chest is open after surgery, or if they have an irregular heart rhythm like AFib, that number becomes totally unreliable. You always have to know the limitations of your tools.
Okay, this brings us to the final and most comprehensive tool in our kit, the Pulmonary Artery Catheter, or PA catheter. You might also hear it called a Swan-Ganz. This thing gives us the most complete picture by measuring pressures on both the right and the left sides of the heart.
So this catheter is this long, thin line that's put into a large vein, and then it's carefully floated through the heart. It's a heck of a journey. It goes through the vena cava, into the right atrium, down through the right ventricle, and finally comes to rest in the pulmonary artery.
And from this one single catheter, we get 4 critical pieces of information. We get our right atrial pressure, which, hey, that's our CVP again. We get the pulmonary artery pressure itself. We get something called the pulmonary capillary wedge pressure, which is a clever way to estimate left-sided heart pressure, and we can directly measure cardiac output. You know, a really simple way to think about PA pressure is that it's kind of like an A line, but for the right side of the heart. It tells us the pressure in the circulation going to the lungs. So if that pressure is high, it could mean there's a problem like pulmonary hypertension, or maybe the left side of the heart is failing and causing a big traffic jam of blood backing up into the lungs.
Now the wedge pressure. This is a really fascinating measurement. We briefly inflate a tiny balloon at the tip of the catheter, and that gives us an indirect look at the pressure in the left atrium. And here's the key takeaway. If CVP is the preload for the right side of the heart, the PCWP is basically the preload for the left side of the heart.
And just like with CVP, that number tells a story. A normal wedge is about 8 to 12. If you see it creeping up, you're thinking about things like left heart failure or maybe just too much fluid on board. If it's low, it again suggests the patient is dehydrated or their blood vessels are too dilated.
So why do we gather all these different numbers? Cardiac output, CVP, blood pressure? Well, because when you put them all together, they let us calculate one final crucial value, systemic vascular resistance, or SVR. This basically tells us how clamped down or relaxed the body's blood vessels are. It's a measure of afterload.
And you can see exactly what SVR means right here. A low SVR means the blood vessels are wide open or vasodilated. Think about what happens in septic shock. A high SVR means those vessels are clamped down tight or vasoconstricted. And managing SVR is absolutely key to managing a patient's blood pressure and making sure all their organs get enough blood flow.
Which brings us right back to where we started. We have all of this incredible data. Preload from our CVP and SVV. Afterload from SVR, the heart's pumping action from cardiac output. The monitor gives us the numbers, it gives us the clues, it gives us the trends. But at the end of the day, you have to put all of that together with what you see at the bedside. The technology is amazing, but the real question, the one you always have to ask is, what is your patient telling you?